Good afternoon and welcome to the Department of Behavioral Health Weekly Update. I'm going to jump right into it. I have a lot of slides today. I promised you last week to talk about vaccines, and so I have some, it'll be like a lecture, okay? It is still National Suicide Prevention Month as well as National Recovery Month. And so we continue with activities for that. And then starting last week, it is National Latino Hispanic Heritage Month. And so you'll see some activities around that as well. COVID by the numbers. Across the world, we're just under 230 million cases of COVID and just over 4.7 million deaths. Overall, cases are lowering across the world. In the United States, we're up to 42,312,485 cases and just under 677,000 deaths. We appear to be on the downward slope for cases, although hospitalizations remain high and deaths are increasing. In California, we've taken a big dip in our test positivity from 4.4 to 2.9%, so that's a nice decrease for the state. If you look on these slides, you can see that we're really getting back down into that coveted 1% or less range, which is when we're really not seeing as much transmission of disease. The third slide is deaths, and those will continue to rise, we anticipate, simply because they trail our surge. All right, in Fresno County, we're up to 125,287 cases with 1,889 confirmed deaths. So we did have 36 reported deaths over the last week. This is indicative of the surge we've been experiencing. You should expect deaths to continue to rise. For Fresno County youth, we've had an additional 1,100 cases in the last week. For hospitalization, it is coming down, but just a little stubborn with it. We're now down to 367 cases, but that's been going up and down between the mid-340s and 371 or 2 or so. So we just can't quite seem to get out of this level of hospitalization. We also have 82 people in the ICU. That remains pretty high comparatively, and only 8 ICU beds left. And so the hospital situation remains very concerning. This week, we should expect to see some additional staffing resources brought in, and that will be a positive as well. For youth hospitalization, this number is coming down. So hopefully what we're seeing here is evidence of a reduction in cases, which is resulting in less hospitalization. In terms of testing trends, we are at 8.2% positivity. That's a slight decrease from last week when we were at 8.6. Nowhere near where the state is at 2.9, and certainly far, far away from the 1% that we would like to be at. For vaccinations, we now have almost 1,100,000. We have 1,083,870 doses given. So slowly but surely marching towards 500,000 people being vaccinated in the county. And for youth, we continue to see this number rise. Last week, we were at 32,166 who were fully vaccinated, and now we're at 33,837. So a nice increase. So cases do continue to decline across the county, hospitalizations dropping, but slower than we would like. We are seeing those deaths increasing and our positivity rate slowly decreasing. You'll see on this slide that stubborn little flat line on the upper graph line that you see, the reddish orange color, kind of shows you that we started declining and then we've kind of leveled off. And so we really need to see that number come down well below where it's at 361. Healthcare workers need a break. They're exhausted. Hospitals are, struggling to provide basic medical services outside of COVID, including elective surgeries that people really had put off with the previous surge. And so we really need to get that hospitalization rate down. And then across the Central Valley, still not a lot of improvement out of the purple tier, but we are seeing in San Joaquin the red tier for positivity rate. So across California, new COVID cases are declining. Had a sharp drop, as I stated, in positivity rate, hospitalizations decreasing overall, and deaths increasing. And then, as you probably saw, the recall election did happen. We talked about it last week. It was happening on Tuesday, and Governor Newsom was not recalled. So nationally, what's happening? We are seeing that overall trend downward, although we have states that remain in surges. I'll show you a graph in a minute to illustrate that. Pfizer has come out and said that their vaccine is safe for 5 to 11-year-olds. It will continue to go through the FDA process to get emergency use authorization, which is the next step in the process. It's anticipated that sometime before the holidays, the vaccine will become available to individuals between the ages of 5 and 11 years old. Johnson & Johnson has produced evidence that a second shot, which we're still calling a booster for Johnson & Johnson, at 6 months increased immunity. They actually studied it at 2 months as well as 6 months. And while both increased immunity, at 6 months it was a much sharper increase. The FDA is now moving forward with a recommendation to give a booster for those individuals who got Pfizer. For individuals over the age of 65 and people under the age of 65 with underlying conditions, as well as people who work in high-risk industries. It is anticipated that healthcare will be identified as a high-risk industry, but this is not finalized yet and will take a little more time. It'll be a little more time for President Biden's recommendations on mandated vaccines to go through the Office of Health and Safety with the federal government, and so that will be forthcoming as well. Studies also came out from Moderna showing that it appears to be more effective in terms of longer-lasting immunity than both Pfizer and Johnson & Johnson, and there is no booster recommendation for Moderna yet. I often get questions about the booster shots. When the official, it's my understanding that right now people can go to pharmacies and such and get booster shots. And so, my recommendation would be if you're very interested in getting a booster shot, you could explore that. But once the recommendation comes out, we'll make sure to let you know how you can get those booster shots and where they might be available. If you got your shots through our clinic, then you got Moderna, and that's going to take a little longer. But again, it is proving right now that Moderna has perhaps higher levels of long-lasting immunity. And so we'll continue to keep you informed on that. So this graph just shows you new reported cases nationally, and you can see on the far right that it appears we've peaked nationally in the aggregate in terms of new reported cases. Tests are lower left, and those continue to go up. Hospitalized looks like it's starting to drop, and deaths are continuing on an upward rise. If you look at particular regions, though, you see a slightly different story. This is cases per 100,000. And so areas like Alaska are really high right now, as well as parts of the South remain a little higher. And so I think it's West Virginia right now has one of the highest rates across the nation. So while you may see overall numbers start to come out when you look at either a state in aggregate or across the states, you will still find hot spot areas because when you're looking at so many different areas with so many different demographics and variables, you often will see some high and some low, which average out. So I wanted to talk about why do we have so much confusion. There's a really good article, I think it's in the New York Times, I'm happy to send it out to anyone who's interested, that just talks about, how does science typically work for healthcare and science around medical innovations. And there's always a lot of back and forth and uncertainty that exists as science is testing the effectiveness of things. And historically, it hasn't played out in the public. So There are what they call preprints or early study results that often come out and are debated amongst scientists, where they kind of pick apart the study to try and find vulnerabilities to ensure that the results that are being reported are accurate. And oftentimes through that process, the research scientists who conducted the study go back and try different things. And that all happens typically within the scientific community. But during a pandemic, when it's really this worldwide outbreak of the virus, a lot of that is happening in real time in the public domain, and can create a lot of uncertainty. And so I found this quote that I think is really appropriate here, that human brains prefer the confident lie to a hesitant truth. So if I tell you something and I have a lot of confidence in my voice and I have a position such as I'm in, where you might think that I'm an authority on something, you're more likely to believe it than if I sat up here and I had no credentials and I wasn't in a position of authority and I seemed like I wasn't quite certain, or I presented the information as if I was hoping you would poke holes in it to help me come up with a decision. And that's just how human brains work. If someone's confident, we'll believe what they say. And so I wanted to go over some biases about why do we see things differently. And some of them I've talked about previously, but I'm going to sail through these pretty quickly. And these are biases, recently with our diversity, equity, and inclusion work, we've talked about implicit bias. So I want to make it very clear that these biases are biases in how human beings think. When we're making decisions, when we're sorting through data or information or beliefs and opinions, these are biases that exist in how our brain thinks that lead us to believe certain things, whether they're true or not. The first one is confirmation bias. And basically what that means is that the human brain welcomes information that confirms what it already thinks, and resist information that disturbs or contradicts what it already thinks. So if you have a belief and you've held very close to that belief, when new information comes in, you're going to resist information that challenges your beliefs, and you're going to welcome information that seems to confirm it. And that's what's called confirmation bias. We tend to be resistant to information that conflicts with what we already believe. Complexity bias is we prefer that simple lie to a complex truth. If it becomes too complex to understand, it's easier to believe this simple thing. So if you hear, for instance, that there was fraud that occurred somewhere, it's easier to believe that than to understand the complexities of why that might not be true. The third is community bias. And the human brain finds it very hard for you to see something that your group doesn't want you to see. So if all of us are in social groups, we might have a group of friends on Facebook or Instagram, we might be a part of a Reddit group, or we might have a game we play with a group of people online, we might belong to a church or some sort of social organization. Those are all social groups that we're in. And so if we tend to put our tribe over the truth. So if our tribe, the people we hang out with, the people we socialize with online or in person, if they believe a certain way, we tend to believe that way. And that kind of makes sense, right? You tend to gravitate towards people with similar beliefs and values as you have. And that's called community bias, or also social confirmation bias. And then complementarity bias. And that is, if people are nice to you, then you're more likely to believe them. So when we become confrontational about our beliefs, so if I say to you, you're stupid for not believing the way I believe, you're less likely to believe the way I believe, even if it makes sense to you. If I'm really nice to you and I'm complimentary to you, you're more likely to at least listen to what I have to say. And so we mirror back the attitude we receive. And then contact bias. If you don't have contact with someone, then you probably aren't going to see things the same way as them. And then next is conservative or liberal bias. So if I'm very conservative, I'm going to tend to believe a certain way. And if I'm liberal, I tend to believe a certain way. And so we'll kind of listen to that political party view and tend to go along with it. And I have a few more biases, believe it or not. Consciousness bias. Our brains see from a person's location or consciousness level that some things are possible and some things are impossible. So depending on how you think about things. Competency bias. And this is a really interesting one. Our brains prefer to think of ourselves as above average. There's a really interesting scientific phenomenon. They did a study and people overestimate how good they are at something. And so we think of ourselves as above average. And so as a result, we're not very competent at knowing how incompetent or competent we really are. And they found this when they studied people taking tests and how well they thought they did on it. And so it's just kind of an interesting thing. And then again, confidence bias. We believe something, a confident lie to a hesitant truth. Conspiracy bias. So when we feel shame or guilt about something, we are especially vulnerable to stories that cast us as the victim of an evil conspiracy by some enemy or other. In other words, our brains like stories in which we're either the hero or the victim, but not the villain. So when we think like somebody in our group or ourselves has done something wrong, we're more likely to attribute that to a conspiracy theory than really facing the reality of what happened. And then finally, comfort. Oh, I've got a few more. Comfort, complacency bias, and we like data that allows us to relax and be happy. We don't like things that make us feel uncomfortable. We don't like things that make us feel vulnerable or that type of thing. And so we like to feel good. And then catastrophe, normalcy, or baseline bias. Our brains are really wired to set a baseline of normalcy and assume that what feels normal has always been and always will be. And so we minimize threats and we're very vulnerable to disasters, especially disasters that develop slowly. So something like COVID, if it had started killing people immediately, it would have been easier to believe than this slow, insidious surges of outbreaks. It's easier to start believing in those conspiracy theories and doubting, science and such. And then the last one is cash bias. And I don't know how it plays into COVID, but our brains are wired within the framework of our economy or what helps us prosper. And that could be make money or live a better life or what have you. And so it's hard to see things that interfere with our way of making a living. And so we're kind of built this way. We're built in a way to see things differently. And some of us believe in science, some of us don't believe in science. Some of us think that all of COVID was a conspiracy theory, and some of us see it as a natural occurrence. We've had pandemics through our whole life. And there's lots of reasons why we believe that way. But we do think differently. And so I wanted to tackle one of the things that we do think differently about, and that's vaccines. And so I wanted to go over some information about vaccines. Vaccines really started with a virus that's been around for thousands of years called smallpox. And smallpox, the technical name for smallpox is variola. It's a variola virus. The first knowledge we have of it was in about 300 BC. They found it in mummies and other types of things that archaeologists have unearthed. It was a highly infectious virus, occurred in outbreaks like all viruses do. You had flu-like symptoms. You would develop these pustule-like rash with fever and vomiting. Eventually the pustules burst, and you can get very extensive scarring. It can be inside your mouth, and it can also cause blindness and can result in death. There are estimates that in the 20th century alone, 300 million people died of smallpox across the world. The very first known efforts at inoculation happened in China as early as the 10th century. And inoculation is really just a way to vaccinate, if you will. And so variolation is a word you'll see used, was an early type of vaccination used with smallpox, which used small pieces of a less virulent form of the virus to inoculate people or generate that immune response. Initially, there are two versions of smallpox, a minor and a major version. The major version caused 30% mortality rate, the minor more like 1%. And so a piece of the minor was used initially, and then eventually a cattle version of smallpox called cowpox. They used that version to create the vaccine. So in 1796, using material from cowpox, a version, today it's a live version of what's called the Vaccinia virus. So the Vaccinia is not smallpox, but it's a virus close enough to smallpox that doesn't have the same effect, the same bad outcomes, but it generates that immune response. And so that then if you encountered smallpox, your body would recognize it and fight it off. So 1796, that first vaccine was developed. It took over 200 years to eradicate smallpox from the world. And it's only one of two viruses that have been eradicated. The other one is called rinderpest, and it is something that animals get, and that's been eradicated with vaccines. So that's the very first vaccine that was developed with smallpox. And we dealt with smallpox for hundreds and thousands of years, and it took a couple hundred years after a vaccine to be able to eradicate it. But most are not eradicated. So the next slide I just want to show you is really showing the different diseases that have vaccines. There's diphtheria, H. influenza or the flu, invasive pneumococcal, there's now a pneumonia vaccine, measles, mumps, pertussis, pertussis is whooping cough, polio. I think I've mentioned this before. When I was younger, I was one of the first wave of people who got a polio vaccine, and so people who are a little older than I am, like if early in my career I worked with people who had suffered polio and still had the debilitating effects of polio, and then rubella and smallpox. So these are really common vaccines that we're all pretty familiar with. Most of us have gotten one or more of these vaccines. Some of us have gotten all of them. I don't think they give the smallpox vaccine to everyone now because it was eradicated. But this is just to give you examples. And then you can see on here that like recent reports in the U.S., very few, like for smallpox, none, polio, none, 6 rubella, little more of pertussis and invasive pneumococcal, and not everyone's vaccinated, so that's pretty normal. And so you can see that most of them have had quite a substantial decrease with the advent of vaccines. And I say this because, of course, the first thing we would look at when we had a global pandemic from a virus was, is there a vaccine that we might utilize? Because we've had success with these vaccines previously. Not everything has a vaccine. HIV does not have a vaccine yet. Ebola doesn't have a vaccine yet, but they're working on them for those. So what does a vaccine do? Well, it's really training your immune system. So when your immune system encounters a bacteria or a virus in nature, not because of a vaccine, those are considered antigens. And antigens are just foreign objects. It could be a toxin or a foreign object that get into your body and try and make you sick. Basically, what they're trying to do is replicate themselves. That's what viruses and bacteria do. They really aren't out to get you. It's just how they work, right? For them to survive, it's a matter of survival. They get inside you and they replicate. And so your body tries to develop an immune response. It says, whoa, wait a second here. This is an intruder. It doesn't belong here. And you have a whole very complex system where you develop essentially little antibody machines that create particles that enable you to fight off this antigen and not allow it to replicate. So if it's trying to get inside a cell or it's trying to access some other part of the cell to replicate itself, your antibodies try and obstruct that. And so it produces those special proteins called antibodies that really try and either destroy the antigen or prevent the antigen from replicating. So when we've been exposed to that in nature, our immune system mounts a response. So what do vaccines do? Well, vaccines try and jumpstart that immune system. And when we really want to have a vaccine is when the virus or bacteria is known to cause morbidity or mortality. Morbidity being you have bad effects of it, bad consequences to getting it, which could be everything from being sick for long periods of time, having blindness like with smallpox, or significant physical disability such as with polio or death, where we really don't want you to have to take the risk of getting the virus or bacteria in order to develop that immunity to it naturally. And so what they do, typically vaccines, and there's different types of vaccines made. I've talked about it previously with the COVID vaccines. Typically they use dead or weakened antigens or some sort of toxin that's related to, or like with COVID, the protein, to trick your immune system into thinking there's an intruder in your body. So not the big intruder that has the resources to take over your cell response and replicate itself, but a piece of it that makes your body say, whoa, wait a second, this is something foreign, let me go out there and attack it. And so once your body knows how to make those antibodies, it stores them in memory cells. So the memory cells are not the antibody. They are. It is really the instructions are stored inside your cell, and the rest of the antigens are destroyed. And then if an antigen ever makes its way back into your body, your immune system says, whoa, wait a second here, and it turns on those memory cells so that it can produce more antibodies and keep you from getting that disease. I know this is kind of scientific, and I apologize. I find it fascinating. Hopefully you will too. We've talked about herd immunity since the very beginning of COVID. And so the reason, vaccines protect individuals. So if I get a vaccine and it causes my body to develop antibodies, I'm less likely, not immune from, but less likely to develop the sickness. And also less likely to spread it to other people. And so it is for individuals, but it also helps entire populations. That's how we eradicated smallpox. The fewer people that can spread or get sick with the illness, the less chance that that virus will live long enough to reproduce itself and stay in the environment. So let's look at measles. And a lot of the slides I'm going to show you aren't about COVID, and I'll make sure to explain that to you. But with measles, if only a few people get vaccinated, so you see on the left-hand side, measles can spread up to 90% of the population. So measles is highly, highly contagious, way more contagious even than COVID. It doesn't cause as many deaths as COVID, but it can certainly cause lots of illness. You can get scars from measles. And so we've worked really hard to get rid of measles. And so if you only have a few people vaccinated, it doesn't work very well to keep everyone from getting measles. But if you get 92 to 94% of the population vaccinated, you really do a much better job of not spreading measles. And so that's what herd immunity is. It means enough of us have either had the illness and developed the antibodies and an immune response, or we've been vaccinated. And that's what we're trying to achieve with COVID. And so there are 5 common types of vaccines now. mRNA vaccines are a newer type of vaccine compared to, what was developed hundreds of thousands of years ago with smallpox. And what it does, and I'm going to go into more detail in a minute, so I'm not going to go into it so much today, but the mRNAs right now the example is COVID vaccines. live attenuated viruses, which means it's a live virus, but it's been attenuated to not be as deadly, are things like the chickenpox vaccine. And so it uses a weakened form of the antigen or toxin. Inactivated uses a dead form of the disease, the antigen that causes the disease. And flu vaccine is an example of that. And then there's conjugate, we're just going to say the subunit recombinant polysaccharide, and conjugate, we'll just call it conjugate, uses a specific piece of the antigen like a protein, sugar, or casein to teach your body that that's foreign. And the shingles vaccine is an example of that. And then a toxoid. So it uses a toxin made by the antigen that causes a disease, and tetanus is an example of that. So that's just to tell you there's different ways of making vaccines, and they're all designed to teach your body that something foreign's in there and to mount a response. So what is it about this new mRNA vaccine technology? Well, viruses do come in different classes. The main types are DNA and RNA viruses. A DNA virus actually gets into the nuclei of a cell where your DNA that makes us who we are lives, and kind of takes it over and uses your own body's DNA in the little cells to replicate. RNA viruses don't ever go into your DNA. They don't impact your DNA. They can't change your DNA. They use a part of the cell called a ribosome to replicate. And so types of DNA viruses are herpes and chickenpox and some other infections. One of the things that can be dangerous about a DNA virus is that when they do interact with your DNA, they can trigger cancer-causing cells in the gene. So human papillomavirus, where we have a new vaccine for adolescents, causes cervical cancer in women and genital rectal cancer in men. So that's an example of a virus where once it gets into your DNA, it can trigger cancer-causing things. And then RNA viruses, again, they don't get into the cell, but some examples of those are COVID being one of them, rabies, influenza, and HIV. And so those are just some examples of the types of viruses and what an RNA virus is. So mRNA technology, really in 1990, scientists discovered that they could use messenger RNA. And remember, these are little strands of cells that go in and just give some instructions to the cell of what to do. And they were able to do it in mice. They created a protein. And in 1992, they sent the instructions to make something called vasopressin, and that instructions was injected into mice and actually resolved a condition called diabetes insipidus symptoms. And that is a disease that causes fluid imbalance. And by putting the instructions for vasopressin, they caused the cells to create the drug vasopressin, which reduced their symptoms. So they were very excited by this. But the problem with mRNA is it doesn't like to be outside of a cell. It's hard to keep it going outside of a cell. And so from the 1990s to the 2010s, they did a lot of work on how to deliver this messenger RNA into cells without it becoming unstable. And during that time, they made advancements in the development of cancer vaccines, allergy vaccines, and parasite vaccines. And so at the time of the coronavirus pandemic, they had a good, 30 plus year, or close to 30 years of working with mRNA type vaccines and with relatively stable delivery systems. Okay, so I know this question will happen. What is a stable delivery system? That sounds scary to me. What does that mean, relatively stable delivery systems? So there are some challenges to mRNA vaccines. One is that the little mRNA strand can elicit an unintended immune reaction, and that just means, it could create a response to maybe not the protein it was trying to create, but just to something else in the strand. And so one thing they've done with that is they've really tried to design those mRNA strands to mimic what they call mammalian cells. So it looks more like an animal cell and less foreign to the body. And then the delivery to the cells is challenging because the way our bodies work, mRNA or RNA in our cells doesn't stick around. It's really instructions and it's ways that things happen in our body, but it's not the process itself. And so our body eliminates RNA all the time. And so it quickly breaks it down. So you need something that delivers the message quick enough that as it gets broken down, it's already done its job. And then the final thing is, because of how fragile the mRNA are, they have to be stored in really, really cold temperatures, which makes it challenging to transport them and deliver them effectively. So that's what it means by a stable delivery system. So, again, how did we come up with this new vaccine? So Operation Warp Speed, which developed under President Trump, made a lot of money available to these researchers who were already working on mRNA vaccines. We certainly had the urgency from the pandemic. People were already dying. And this massive government funding really allowed them to address the formulations of things like the mammalian, mimic the mammalian cells and work on how it would be stored. And how you could deliver that quickly. One of the things they did is how they deliver it. The medium can protect the mRNA long enough for it to do its work. And also to conduct large-scale trials. And we've talked about this before. Typically, there's some preclinical work that goes on that had already happened with mRNA vaccines. And then there are progressive trials, phase 1, 2, and 3 trials, where they start it first with people who've been exposed to a virus, and then they start, that's like less than 200 people are given it, and then it progresses to more people where the different dosages are tested, different schedules of delivery, so maybe just one dose or doses 21 days apart versus 28 or 64 or whatever, and then they go to massive amounts. And so all of that can happen sequentially, or it can happen at the same time. And in the case of being in the midst of a pandemic, they conducted those studies all at the same time. And so pretty large numbers, 30 and 43,000 people in the Moderna and the Pfizer trials. So what happens if something goes wrong? I've heard a lot about, well, we don't know what these vaccines do, and how do we know that they're not hurting people, and I heard someone got sick, or I heard someone died, etc. And so there's a very comprehensive monitoring system that occurs even after approval of a vaccine. So not just when it's in emergency use, but like Pfizer, once it's went through the approval process and now is an approved vaccine. And what that's designed to do is to detect new, unusual, or rare vaccine events. We've talked about this previously. In a trial of 30 to 43,000 people, you're going to see things that happen once in 30,000 or more frequently, and once in 43,000 or more frequently. But you're not necessarily going to see things that happen once in a million. That happens once it's out in production. And so they continue monitoring to find even those very rare things. You monitor increases in known adverse events. You identify potential risk factors. So, with some of the vaccines, we found that it affects teenagers differently or women differently. And then you identify any vaccine lots that have an increased number or type of reported adverse event. Maybe there was something with the manufacturing process in that particular lot that you had outcomes different than any other lot. And then you assess the safety of newly licensed vaccines. So there's a system in place for that. And they use a vaccine adverse reporting system. This is a voluntary system. And so there is some reliance on people to report. They feel that with a voluntary reporting system, you get an underreporting of mild adverse events like fever and pain and that type of thing, but you get a good reporting of significant events. People are more likely to report if someone died, for instance, or there was a stroke or something significant. There's also some other programs, the FDA Sentinel program, a vaccine safety data link, et cetera, that are places for this information to be coalesced and reviewed. It is for sure there can be bad events that happen consistent with when a vaccine was delivered that aren't necessarily from the vaccine, and having these large databases allows them to sort through that and determine what was likely caused by the vaccine and what was not. So really what it comes down to is you have to each manage your own risk. And this is an example with measles. There's 139 motor vehicle deaths per 1 million people annually, 99 unintentional poisoning deaths, and less than 1 serious allergic reaction to MMR vaccine. So you have to weigh your risks. There are risks associated with vaccines, but you have to put them into perspective. How rare is that compared to things we just do every day? And then when you look at side effects, you have to compare that to the infection risks. Well, there's a risk that something bad could happen with the vaccine, but maybe it's significantly higher that a risk could happen if I got the virus, if I wasn't vaccinated. And that's really what we've been preaching about COVID, is that yes, you might have a risk if, for instance, you have a compromised immune system, but if you have a compromised immune system, you're also much more likely to fare poorly if you get the virus. And so again, that's how you have to weigh your risk. And this particular example is another type of vaccine for meningitis. And then the next one is, just looking at the facts. Yes, here's some side effects with a rotavirus vaccine clinical trial. Vaccine group and placebo group had the exact same responses for the most part. And so yes, there are side effects, but not necessarily from the vaccine itself, maybe just from getting a shot. So with that was my attempt to kind of give you a little bit of background on vaccines, and particularly the mRNA vaccines. I know there's a lot of hesitation and concern, and I just want to provide you with facts that hopefully will help you as you make a decision for you and your family. All right, over to the questions. It looks like there's a lot of them today. Why do I think that the positivity rate has decreased so much over the past 7 days? What can it be attributed to? Well, this is purely my speculation. I think it can be attributed to multiple things. We definitely went through a surge. Anytime we go through a surge, most people, maybe not all people, kind of modify their behavior. I know I started wearing my mask again in stores and things like that. Tried to not be in situations where I could be at risk, so we could have modified our behavior a fair amount. We also did have a lot of people who got COVID during this period of time, and that creates a sense of immunity. If you get COVID and you recover, you're not going to get it again right away or pass it on to people after you've already had it. And some people are hospitalized or died. And so there's just most viruses occur in surges like this. I will say in all the literature I've read, there is some just unknowns. We don't always understand why we come out of a surge the way we do. We certainly can't say right now, well, so many more people got vaccinated and that's why we got out of the surge. It just seems to go through that kind of cycle, these surges. What will happen to our leave if we don't use it after September 30th? I am not sure what SPSL leave is, and so, and I'm not today, I don't have specific information about what the consequences will be after September 30th. I've shared that previously with all of you, that is, Maine HR is working on that with our county council and such, and so stay tuned on that. Is it known how long Moderna effectiveness lasts? No, it is not known. What they are saying right now is it appears to be have some long-lasting effect, but again, not enough time has passed for anyone to definitively say that the antibodies have become ineffective or that it's still, as effective as it was initially. Initial studies have shown that people who got Moderna, Pfizer, and Johnson & Johnson have more resistance to getting the virus as well as getting as sick with the virus than people who are unvaccinated. And so that's for sure what we do know right now. Is it about gain of function research? The New York Times article. There's a lot of controversy about gain of function research. I'm not going to get into that here because really it's It doesn't have any impact on what we're doing right now. There's questions about, did people benefit from research into coronaviruses that are in high levels of the government? Did that have some, how did the virus get out in terms of being a pandemic? Was it truly, an animal to human transmission, or did it come out of a lab? At this point, it doesn't really matter. It's here and we have to deal with it. That's just my opinion. It's easier to fool someone than to convince them they've been fooled. You're right. Yeah, an example of cash bias could be the controversy around shutdowns and limits to restaurant occupancy. Definitely people who felt or were worried about their income being impacted by some of the public health measures would want to say this is all blown out of proportion because they don't want to believe that they have to suffer economically in order for us to do what we need to do to contain a pandemic. I understand that. If I was a business owner and I felt like my business was going to go under, I would maybe be resistant as well. I understand that. Or big pharma closing all paths to therapeutics. I love this one. The paths to therapeutics are there. There's a huge push right now to do monoclonal antibodies, which is Regeneron. I've shared this previously, but because this keeps coming up, I'll share it again. The challenge with monoclonal antibodies is multifold. One is that you have to really, to have the best benefit of monoclonal antibodies, you take it before you get sick enough to go in the hospital. So most people, when they get sick, think, I'm going to be fine. And they're not necessarily going and seeking help. They go, well, I'm supposed to stay home and stay away from everyone. And by the time they realize they're that sick, it might be too late for monoclonal antibodies to work for them. The other thing is to make monoclonal antibodies available, it's a pretty labor-intensive process and it requires nursing staff. And I don't know if you've noticed or not, but we're short on nursing staff right now because the hospitals are full of COVID. And so, and a lot of nurses are quitting the profession because they're just exhausted emotionally and physically from both dealing with COVID and dealing with anger and harassment out in the community when people mock them because they work in healthcare. And so to staff the monoclonal antibody clinics is challenging. So one of the things they're doing right now with monoclonal antibodies, because it does hold promise, is they're encouraging areas like skilled nursing facilities where highly vulnerable populations are to get prepared to deliver monoclonal antibodies at the first sign that one of their residents has COVID and might benefit from that. And they're really trying to encourage, private practice doctors and other types of clinics to offer the monoclonal antibodies so that you're not just reliant on hospitals to do it, because the hospitals need their staff to care for not just COVID patients, but patients who've had a heart attack or have been in a car accident. And so that's one of the challenges with monoclonal antibodies. But, frankly, it's a little disingenuous to say that we haven't worked on treatment. We've massively changed treatment. In fact, I think we've impacted morbidity and mortality with the treatment. So initially, things like putting people on their stomach. In the beginning, they were putting everyone on a ventilator. Now they try and do everything they can to keep people off a ventilator. Remdesivir is a treatment that they do while someone's in the hospital. Dexamethasone is a treatment, and all of those things are proving to be effective. And so I don't know about you. I personally would rather take a vaccine with the hope that I would keep myself from getting hospitalized than say, well, when I get hospitalized, they better have a treatment that fixes me, because that's just not how medicine works. There's lots of illnesses that once you get it, it's like many people who have been unvaccinated end up in the hospital and are asking for the vaccine to save them. Unfortunately, it's too late. And most of those people have gotten remdesivir and dexamethasone, and they're on their stomach, and they're trying to keep them off a ventilator. And so I just can't emphasize this enough. It's very disingenuous to suggest that there's no effort to provide therapeutics. Tremendous work is going into therapeutics. But we just haven't developed that magic bullet that works as effective as a vaccine at this point. And someone else said that too. You're less likely to need therapeutics if you've had the vaccine. All right. Why is natural immunity not enough then? It seems like we know as much about that as you that just as you explained, our bodies do their job. Natural immunity for some viruses is lifetime. So there are some viruses that if you get them and survive, you can't get them again. But not all viruses are like that. Wouldn't it be a great thing if viruses were predictable or bacteria were predictable? But unfortunately, there's vast differences in how infectious they are, how sick they make you, and the likelihood that they could cause your death. So for some viruses, the common cold virus, we haven't developed a vaccine for it yet. We don't worry about it too much. We don't wear our masks every year because we could get the cold and such, because the chance that you'll die from it isn't that great, and you might have enough natural immunity to keep from getting too sick. Now, if you're older and you're more prone to have pneumonia, then we want you to get the pneumonia vaccine, because that common cold could turn into something worse if it was a pneumonia. And so, you know, natural immunity should not be discounted. For those of you who've had COVID, you do have some immunity. And you might have some good justification for saying, I'm going to wait on the vaccine, or I don't think I need the vaccine. I think studies will show over time they'll be able to compare that natural immunity to the immunity generated by a vaccine. Early studies have shown that the vaccines are generating, they think, better immunity, but I think time will really prove that and tell. But again, this is a virus that is killing, I believe now it's killed more people than the Spanish flu in the United States. And so you just have to weigh those risks. Is it, do you believe in natural immunity enough that you're willing to take the risk that if you got COVID, you would survive and have that natural immunity protecting you, and you're willing to take that risk as opposed to your perceived risks of the vaccine? For me personally, I'm not willing to take that risk. I have a friend in the hospital right now who has significant complications from COVID and was unvaccinated. I believe that the choice made to be unvaccinated, I understand why that was made for this particular person, but significant complications have occurred. So I've seen it in my life, and that helps me make that decision that the risk of the vaccine for me is far less than the risk of getting COVID, maybe spreading it to someone else, and potentially, even if I was okay, causing a problem and then. But you have to make your own decision about that. But natural immunity is real. It does occur. It can help people, prevent them from getting COVID in the future. It's just you have to get COVID to get it. That's the downside. Someone else said, nothing beautiful about being forced to take a vaccine. Understand that. It's also not beautiful, frankly, to come to get care in a place where we can't, assure that you'll be safe from getting COVID. And so that's the dilemma, right? I don't want to force anyone to do anything, and it's not me forcing you to do it, but it is a challenge, in healthcare environments where we're really struggling right now. Hospitals are barely keeping their heads above water. There is the perception that when someone comes to get health care, that you won't make them sick. And so that's the challenge for us right now. And then SPSL, supplemental paid sick leave. And I will have to have somebody else answer that question. The Wall Street Journal stated that natural immunity was 27 times more effective than vaccinated immunity based on an Israeli study. That's quite possible that will prove to be true. I know that was a preprint of an Israeli study, which means it hadn't went through a rigorous scientific process, but it is possible for sure that as time passes, we'll learn more about natural immunity compared to vaccine immunity. Again, in order to have natural immunity, you have to get COVID and take the risk that you will survive it and that you will not have lifelong problems from COVID. So again, if that's, you have that choice to make. Natural immunity, if it's proven to be more effective, that's great for people who happen to get COVID. But I, for one, don't want to have to get COVID in order to get it. Yeah, the same study, someone said that with a single dose of vaccine, people also gained additional immunity regardless of their previous infection. So isn't science great? We learned so much. Isn't this all consistent with Darwin's theory? Well, survival of the fittest, we'll see. It may very well be that people who are unvaccinated will survive, or vaccinated. I don't know. That is a philosophical question that's far beyond my pay grade to answer. Okay, we have a couple of questions via text. All right. Given the increase in serious illness hospitalizations of children under 12 with the Delta variant, I have great concern about putting clients' preferences first over the health of others. I have clients that have refused a vaccine, or a caregiver that refused to vaccinate. I'm personally vaccinated but have children under 12 at home who are unable to receive the vaccination. I recognize balancing competing needs in crisis situations offers more than debate, but true ethical dilemmas. So this person just said, please address the following question. When other methods of receiving services exist for the client, must we provide in-person services to unvaccinated clients if providing that service of preference is risking staff transmit COVID variants that can seriously harm and infect their children? That's a question that we'll have to debate and make some determinations about. The good news is vaccines will soon be available for individuals 5 to 11 years old, but certainly that's something that we can talk about as we move forward. We have created environments, or we're working on creating environments as we bring people in to create safe environments, and we'll just have to look at that as we move forward. These are complicated, oftentimes ethical decisions, and so sometimes it takes time to come up with answer. Oh, are you aware of or have any information the $500 from the Board of Supervisors for being vaccinated? Thank you for asking that question. So there was a lively debate this morning at the Board of Supervisor meeting. First, I'll just mention, I had to validate some of this information, but the board did approve this morning for unrepresented staff and management a 2.5% pay increase. And also, and this is really important, an increase in the employer portion of the paid insurance premium. So I believe it's about $100 more that they're paying toward employee only, and upwards of almost over $200 toward families. So there was some real kind of inequities there if you had a family paying a lot of money out of pocket. So this is a way to put money in your pocket, which I'm really, really excited about. So a little bit of a pay increase, but also for all employees who participate in our health insurance program, an increase in what the county contributes towards that premium. So that will be less money that you have to contribute, more money directly in your pocket. And so that's awesome. In terms of the vaccine incentive, there was a lot of debate. What was proposed is that the county is incurring significant costs to test people who are unvaccinated. Right now, there's a whole slew of county staff, certainly healthcare staff, but also jail staff and some other law enforcement type staff who are mandated to be tested if they are not vaccinated. And so the county incurs something like $70 or $80 per test to test individuals who are unvaccinated. And so the proposal was to give people who are vaccinated $500 in a 457B account. That's a retirement account. It's non-pensionable. If you didn't have a 457B account, one would be opened for you. Those accounts cost about 8 cents a month, less than a dime a month to have. And for those of you who aren't contributing, maybe it would be a way to incentivize you to contribute more towards your retirement. But anyhow, that proposal was not acted on by the board. They didn't vote against it. They didn't vote for it. They had a debate. Everything from believing that we shouldn't be spending the American Rescue Act money on this particular thing, that there were other uses of the money. It was pointed out that $500 would be used up pretty quickly if you're testing unvaccinated folks, and so if we could get people to get vaccinated, it would save money. And so eventually the board just chose not to act on it. They agreed that they would table it and possibly bring it back to a later date. So that vaccine incentive was discussed at the board meeting, and it was not acted upon. So at least for now, that will not happen. All right. It was a busy one today. I gave you guys a lot of information, some of which clearly is debatable. For those of you who asked questions that you're not super happy about my answer or didn't feel I gave a thorough answer, we'll keep working on those. Feel free to send me an email to remind me to follow up on that. And we will continue to work diligently with you, for you, alongside you as we hopefully emerge from this surge and, please God, not get into another one anytime soon, if at all. Thank you for your time and attention and listening to this very long presentation, and we will see you next week.